Hi everyone. We'll make a start. Could I get just a thumbs up or something that you can hear me? Not seeing anything come in. Could someone just send a thumbs up, just confirming you can hear us in the chat?
I can hear you, but
I'm gonna send a message in case. Okay, perfect. Great. Okay, guys, we'll make a start. So, hello everyone. Thank you for joining us today. So my name's Luke. I'm one of the education directors at SUPTA, and this week we're focusing on cardiothoracic surgery. So we're excited to have you all with us, and thank you for joining. So today I'm joined by Esther Slay, who will give you kind of an overview of the topic of lung cancer. Esther is a medical student from the University of Nottingham. To make this session as engaging as possible, we will be releasing polls throughout. So these are completely anonymous, and we encourage you to participate actively. If you do have any questions during the session, please pop them in the chat and we'll do our best to address them. At the end of the session, we'll share a feedback form, and if you complete this, you will receive a certificate of attendance and exclusive discount codes for Teach Me Surgery and Pass the MRCS. Additionally, this session is being recorded, and the recording and slides will be shared on our medal page a couple of hours after the session, so keep an eye out for that. We are also excited to share that an exclusive question bank and other resources will be available on our learning portal, so check out our website to access them. If you create a free membership account with us, you'll also receive a discount code for 10% off the Geeky Medics anatomy flashcards, surgery flashcards, and knowledge bundle. We also have an exciting opportunity for all our attendees. So 2 lucky people will win free access to the Geeky Medics surgical flashcards and the Geeky Medics OSCE stations. To enter, simply complete the Google form, which will be sent at the end of the session, and enter the unique code that we'll provide. The more sessions you attend, the higher the chances of winning. So be sure to stay until the end of the session and attend as many of our sessions as well. And finally, just before we begin, we'd like to thank our partners, the Royal College of Surgeons England, Geeky Medics, the NDU, More Than Skin Deep, Medal, Teach Me Surgery, and Pass the MRCS. So without further ado, I will hand over to Esther.
Thanks, Luke. That's great. So hi, everyone. So yeah, I'm Esther. I'm one of the final years at Nottingham. And today we're just going to be talking about lung cancer, go through a bit of anatomy and like the clinical relevance. So as Luke said, like thank you to our partners. And just to start off with going through the learning objectives. So there's quite a few. So these are the anatomy ones. I'm not going to read them all out. And then there's also the clinical objectives of lung cancer. So I'll just be going through the different types, how to diagnose the symptoms, and then some little bit of a surgical relevance at the end, as it's a surgical talk. So stay tuned for that. So to start off with, some anatomy. So as you all probably know, the thorax is subdivided into 4 parts. So you've got on here the diagram at the side. You can see the superior and the inferior, and then the inferior is divided into the anterior, middle, and posterior, and that border is at the sternal angle. So I'm just going to go through kind of each subdivision to start off with, just so everyone's aware of what anatomy is in which part. So the superior mediastinum and its contents. So you get the great vessels. So you've got the arch of the aorta and the 3 branches that you can see on the diagram at the side. Then you've also got the superior vena cava and the 4 drainage into the superior vena cava. You've got the nerves, so the vagus nerve, the left recurrent laryngeal, the phrenic nerve, the cardiac nerves, and the sympathetic trunk. and then some others that kind of pop in and out of the superior and inferior. You've got the thymus gland, the trachea, esophagus, thoracic duct, and muscles. The anterior mediastinum. So this is probably the smallest area of the thorax, and its main contents is the thymus gland, which you can see, this is a cross section at the side. It does usually shrink as you get older. The branches of the internal thoracic vessels, and also the sternopericardial ligaments and the loose connective tissue. So that's everything that's in front of the heart but behind the ribcage and sternum. So the middle mediastinum, you've got the main content is the heart and pericardium, and then behind the heart and pericardium you've got the tracheal bifurcation and the left and right main bronchi. There's the vessels as well, so it's the origin of all the great vessels, as obviously your heart is in the middle. So you've got the ascending aorta, pulmonary trunk, SVC, IVC. Your nerves, you've got the cardiac plexus, and the phrenic nerves, the left and right, and then the lymphatics, which are the tracheobronchial lymph nodes. And these are important for clinical relevance and when you find abnormalities with them. So just have a think what conditions, what certain lung pathologies might have enlarged lymph nodes. Just have a think what might cause it. So the posterior mediastinum finally is right at the back. So it's the posterior thoracic wall. So you've got your rib cage at the back and your vertebrae, and then in front of that you've got your thoracic aorta and its branches, the esophagus, the thoracic duct system, and your sympathetic trunks. Also, if you have any questions at all throughout the session, please just put your messages in the chat. Okay, so moving on from mediastinum, we're going to look at the anatomy of the airways and the lungs itself. So it's kind of split into the upper and lower airways. So your upper airways, you've got your nasal cavity, nasopharynx, oropharynx, larynx. So that would be mostly up the top here. And then your lower airway is from the trachea downwards. So the trachea, the bronchi, bronchioles, alveoli, and then right at the bottom, you've got the diaphragm, which is not really the airway, but it makes up part of the anatomy. So the trachea are C-shaped cartilaginous rings arising at the lower border of the cricoid cartilage, and it bifurcates at the sternal angle. So, and why is this relevant? Why do we care about what way the bronchi are placed or anything like this? Because the right main bronchus is shorter, wider, and more straight. So often when children inhale foreign bodies, the foreign body will sit in the right main bronchus. So it's important, as that's where you should look first if you ever have to go in to try and remove a foreign body, as that's where it's most likely going to sit. Obviously, there's exceptions to everything, but that's the most likely place. So going further down now to the bronchial tree. So you've got the main bronchus, the lobar bronchi, segmental bronchi, terminal bronchioles, and then the alveoli. And each of the lung and its bronchus they're in segments. So on the right, you've got the 3 lobes and 10 segments, and on the left, you've got the 2 lobes and 10 segments. So there's still 10 segments both sides, and there's some variation of diagrams as some segments are kind of squished together a little bit on the left. And I'm not sure if you need to know this for your exams or not. I mean, it might be helpful later down your career, but these are the different these are the names of each segment, so you can remember the right ones with a palm seed makes another little. So the apical, posterior, anterior, lateral, medial, superior, medial, anterior, lateral, posterior. So basically, as you just go down, it's apical, posterior, anterior, or lateral, medial. And then on the left, you can remember it as Alps. So you can read it there as the apico-posterior, which can be split in 2. The anterior superior lingular, the inferior lingular, superior or apical, the anterior medial, which can also be split into 2, and then the lateral and posterior. So you can kind of see on the diagram how it all works out. Again, so why do we kind of need to know each segment is that so in the lungs, they're quite clever. They have their own bronchus and blood supply to each segment, which means they're anatomically discrete. So when you do have problems with your lungs and you need surgery, surgeons can go in and resect segments of the lung without affecting the gross lung function, because each of them are discrete in their anatomy. So it's also important you know what goes where and what segments where, because you don't want to remove the wrong segment by accident. So then moving on to the lung hilum. This is the medial aspect of the lung. So it's the connection between the parietal and visceral pleura at the mediastinum. And it's a triangular depression, roughly around T5 to 7 level. And it's got quite a lot of content. So you've got the bronchus, the pulmonary arteries, the veins, the bronchial artery and veins, the nerve plexus, lymphatics, bronchial lymph nodes. So just to have a think about, you can put some answers in the chat if you like. Why are the hilum of the lungs important in clinical practice, and what abnormalities might they demonstrate? So either have a think, or in the chat, I'll leave it up for just a second, and we'll see if there's any.
So I'll let you know if anything comes through.
That's great, thank you. Sometimes when you can see the different abnormalities, you can see them on the chest x-ray, you can see them on a CT scan, you might be able to hear something when you listen to the chest. Just have a think. Doesn't matter if no one puts anything in the chat, it's okay. I'll go on to it on the next slide.
Yeah, nothing yet, maybe.
No, that's fine, we can go on to the next slide. So the clinical relevance of the lung hilum. So there's kind of 3 major abnormalities. You've got the bilateral enlargement, unilateral enlargement, and abnormal hilum position. And each of these 3 things kind of highlight something different. So when you've got bilateral enlargement, it's mostly something like systemic. So like TB, sarcoidosis, lymphoma, pulmonary arterial hypertension, because it affects both sides. You can occasionally get metastatic malignancy as well, which will enlarge both hilum. But it's more common to get unilateral enlargement with lung cancer, because sometimes it can be it's quite localized disease, so it's only spread to one half of the mediastinum and affecting the lymph nodes at the hilum. And then abnormal hilum position. Some things you see this in is pneumonia. So the consolidation will pull the hilum towards the affected side. And then in a pneumothorax, it will push the hilum away from the affected side. So I've just got some two polls. So please vote. So what does this chest x-ray show? So hopefully a poll should come up and there'll be 3 options for you to click from. And it's just this chest x-ray on the left. So why do you think this, what do you think the abnormality is on this chest x-ray? I'll just wait for a few more responses. There's still some coming in. Okay, so we've
I
had.
think you can see. Yeah.
Yep, happy. So in this chest x-ray, this is bilateral hilum enlargement, and actually more suggestive of sarcoidosis. This is because there's abnormalities on the x-ray in the terms of the lung fields. With TB, you might expect to see some apical lesions, and with metastatic malignancy, you might see the traditional cannonball metastases in the lungs, or you might even see the lung tumor itself. And then we've just got one more as well. So just the second poll for this chest x-ray on the right. If you could vote for which abnormality you think is happening here. Okay, so we've had about 10 responses back as well, like the last one. So majority of you actually put the unilateral hilar displacement due to a pneumothorax, which is correct. So if you can see my mouse, I'm not sure if you can or not, if you can, but there's a triangle area on the left lateral side, and this is characteristic of a pneumothorax as there aren't any lung markings. Just some other abnormalities on the x-ray, not exactly abnormalities, but you can see these kind of circular white dots on the chest. These are external ECG stickers. So if you ever see something like this on an x-ray, that's what it is. Okay, so moving on to the lobes and fissures of the lung. So as we said before, the right has the upper, middle, and lower, and on the left there's just the upper and lower. And on this picture, you can see how they sit in the chest. So as a 2D image, the superior lobe on the left is pretty much all of that, and the inferior lobe is right behind it. Then your fissures, you've got the horizontal fissure on the right-hand side, separating the superior and middle, and then you've got oblique fissures on both sides, separating the middle inferior and the superior inferior. And then you also have some accessory fissures, which you can sometimes see on x-rays, but not always. So this is kind of the different lobes on an x-ray, as obviously you're looking at a 3D structure on a 2D image. So have a think about each of the colours, what lobe corresponds to each colour, and I'll just go through them in just a second. Okay, so the red on the left, on the right here, sorry, is the right superior lobe, and you can see it on the lateral chest x-ray here. So it's basically the entire of the superior right lung. Then the green is the right middle lobe, and then just right at the bottom you can see the purple in the corner by the diaphragm, which is the superior lobe on the right hand side, and it's more clear on the lateral x-ray as well. And then the left-hand side is a bit more simple. You've got the yellow, which is the superior lobe, and then the blue again, poking out at the bottom, which is the inferior lobe. And you can see a bit more clearly on the lateral. So thinking about when you're interpreting chest x-rays and how you describe things, how would you describe where an abnormality is on a chest x-ray? So there should be a poll for this. Two answers. So would you describe the abnormality in lobes, or would you describe it in zones? Okay, so we're almost 50-50 split here. So the way I got taught to describe chest x-rays is in zones, because if we go back to this picture, if you've got an abnormality in a lung, remember you're looking at it 2D image. If you've got something right in these corners down by the diaphragm, you don't actually have any way of knowing if it's in the middle lobe or the inferior lobe, or on the left hand side in the superior lobe rather than the inferior lobe, because it might superimpose. So I've got some examples here. So on this chest x-ray here, you would describe this abnormality as the right lower zone, because from this image you can't tell whether it's in the lower zone, lower lobe, sorry. And on this x-ray it's the same. You can't tell from whether this consolidation in the left hand side is in the superior or inferior lobe. So you would describe this as a left lower zone classification. Just a little tip when you're like looking at x-rays and things, because they can come up in these. Okay, so a little bit further on with the chest x-ray anatomy. So there's some key things that you kind of want to look at, and everyone has their own structure of interpreting an x-ray. I like to use the ABCDE model, just because then I don't end up forgetting about anything. And some people put ripe or DRIPE or something in front of it. So demographics, rotation, duration, exposure, and so it's PA or AP. So looking at this chest x-ray on the side, you can see the diaphragm, which is highlighted by this dotted line. And then below the diaphragm, you've got the liver and the stomach. So seeing a bubble is a normal thing you would see X-ray, chest X-ray. It doesn't mean they're below the diaphragm if you can see the gastric bubble. Important things to note on the you need to check both the cardiophrenic and the costophrenic angles as common sites for pleural effusions to develop. Then you do the cardiothoracic ratio, so how big the heart is compared to the chest, but you can only do this on a PA chest X-ray. And then you've got the cardiac contours, so the left and right side of the borders, and the mediastinal contours, like the aortic knuckle, which you can see on the chest X-ray here on the left. I'm not sure if you can see my mouse or not. I don't so. Okay, so there's kind of an outbulging next to the trachea in this chest X-ray, and that's called the aortic knuckle. So that's also a normal appearance for chest X-ray. And then, as I said before, you can sometimes see accessory fissures on a chest X-ray. I don't think you can see it on this one, but you can sometimes see the right paratracheal stripe or an accessory fissure. And I've already answered this, but it's important to check the costophrenic angles bilaterally, because just because one of them is clear doesn't mean the other one will be. Okay, so lymphatic nerves. We'll just touch this briefly. So the lymphatics, there's two plexuses. You've got the supa, which drains the lung parenchyma, and then the deep, which drains the structures of the lung root. And they both drain into the trachea, bronchial node, and then to the bronchospinal trunks. So that's why it's so important to look at the lymphatics at the lung hilum. All of the lymphatics of the lung will drain there. So if there's any abnormality in the lung at all involves the lymphatics, your hilum will be affected. Okay, and on the nerves, you've got the pulmonary plexuses, sympathetic to the vagus nerve, and this stimulation from the bronchial glands, the contraction of bronchial smooth muscle, and vasodilating of the pulmonary vessels. You've got the sympathetic trunks, so that stimulates relaxation of bronchial smooth muscles, vasoconstriction of pulmonary vessels. And then you've also got the visceral afferent, so that conducts pain impulses to the sensory ganglion of the vagus nerve. Okay, that's fine. Okay, almost there with the anatomy. There's quite a lot in the thorax, so apologies. And I hope I'm not going to just put a message in the chat if you want me to go back to anything at all.
Esther, your audio is slightly grainy. I don't know if it's your microphone or are you able to try with that? I can still understand you just a little bit.
Okay, I can. Is this better if I speak into the microphone a bit more? Okay.
Hello.
Sorry, Luke, is the microphone like this?
No,
or I can take my headphones out.
Without the microphone, or you need it?
Yeah, that's fine. I can take my headphones out. Is this any better? Is that any better now?
Say something again.
Is this any better?
No, I think it's right. It might be the Wi-Fi or something. If you just, it's probably better with. I think it was better.
Okay, sorry about that. Okay, I'll try and speak more clearly and right into the microphone. So if there is a bit of patchiness, it's a bit better. If it does get any worse, I can hotspot. So just let me know. Okay. So we'll go on to the arterial supply of the thoracic wall. So you've got the thoracic aorta, the sclavian artery, and the artery. And you've got the internal thoracic or internal mammary arteries. So these are the subclavian artery, and they supply the intercostal muscles, the parietal pleura of 1 to 6 intercostal space, and indirectly. And then there's the 5 branches given off and there's a mnemonic to help you remember the names of it. Mummy swallowed, ancient papyrus scrolls. So you've got the musculophrenic, the superior epigastric, the anterior intercostal, the perforating, and the sternal. The neurovascular bundle in the interspaces. So the location is the located costal group between the internal and innermost muscles. And then you can remember the order they are in. So you've got the veins, then the arteries, and then the nerves. And why is this important? Because in thoracic surgery, the access points for a thoracentesis or a VATS procedure is through the intercostal spaces. So you don't want any of the anatomy that's there and cause the damage. And then for cardiac surgery, when you do a coronary artery bypass graft, you use the collateral artery supply for the cabbage. So the lemur, so the left internal mammary artery, and that goes to the left anterior descending artery. Okay, so that was quite a lot of anatomy to go through. Most of it was familiar. If it wasn't, just put any questions you've got in the chat, and hopefully my audio is a little bit better. I'll just have a little pause, and then we can go to.
If you try turning your camera off, it might be a Wi-Fi issue.
Yeah, that's fine. To be fair, I can try my hotspot because it worked last time on my hotspot, if that's easier. So. Is that any better with the audio?
Did you switch to hotspot?
Yeah, I've switched to hotspot.
Okay, well, yeah, we'll give that a go.
Okay, is it any better or not?
I can't hear you at the moment.
Okay, I'll turn off my video as well. Just
Sorry guys, won't be too long.
All right, we'll start again. Hopefully the audio is a little bit better. Oh, I can hear an echo now.
Just go for it. I think it.
Okay. Okay. All right. Can everyone see my slides again? Okay. We'll start back on the clinical side now. So we've gone through a lot of anatomy, and I know it was a bit quite fast, so well done for keeping up. We'll just go through the clinical side now, so focusing more on lung cancer. So lung cancer is classified via the histology. So you've got small cell lung cancer, non-small cell lung cancer, and then mesothelioma. So the non-small cell lung cancer are the most common, with adenocarcinoma, squamous cell carcinoma, large cell carcinoma, and then some other types. Your mesothelioma is the cells of the pleura, and it's linked to asbestos inhalation. And there's often a latent period between the exposure to asbestos and the cancer, but it's usually diagnosed in and around when you're 45, and it's quite a poor prognosis, as it's not curative. You have chemotherapy to palliate you and to improve symptoms. And with the small cell lung cancer, there's often quite a few paraneoplastic syndromes and extrapulmonary manifestations of the disease that can be recognizable. So your risk factors for lung cancer: smoking is a big one, age, family history, passive smoking. So if you grew up in a house where your parents smoked and you were around them when they smoked, radon gas, air pollution, occupation, so asbestos, silica, any radiation, and then if you've had previous cancer treatment, so radiotherapy for lymphoma or testicular cancer, it can often represent as lung cancer. And then if you've also got lower immunity, like HIV, or you take immunosuppressant drugs, you'll also increase your risk of lung cancer. So the clinical features of lung cancer often are shortness of cough, hemoptysis, finger clubbing, recurrent chest infections is how it can often present, weight loss, so your B symptoms, your weight loss, lymphadenopathy, fatigue, and then also these paraneoplastic syndromes. So you can get laryngeal nerve palsy, so you get a hoarse voice if the tumour is affecting the nerve. You can get phrenic nerve palsies. You can get Horner syndrome, SIADH, Cushing syndrome, hypercalcemia, limbic encephalitis, Lambert-Eaton myasthenic syndrome, and then also superior vena cava obstruction. And I'll speak a little bit more about that. So there's quite a few here, and they're good kind of signs to pick up in questions, as they can point you towards which lung cancer it could be. So Lambert-Eaton syndrome is quite characteristic of a small cell. So this is caused by antibodies against small cell lung cancer, and they damage the calcium channels. So you get proximal muscle weakness, intraocular muscle weakness. You get ptosis, diplopia, slurred speech, dysphasia, and then you also get your autonomic dysfunction, so your dry mouth, blurred vision, impotence, dizziness. So it could be quite similar to like a myasthenic presentation. And then you've also got Horner syndrome, which is quite a good exam question as well, because you get that classic triad of the ptosis, anhidrosis, and meiosis, and that's often a Pancoast tumor, which affects the apex and presses on the sympathetic ganglion. So about superior vena cava obstruction. Where is that? Oh, I've actually missed a slide. I'll come back to superior vena cava obstruction. So just another, although there wasn't a poll for this one, but if you could just put in the chat, what do you think some lung cancer red flags would be? I've mentioned quite a few of them already, but
Can you see them, Esther?
Yeah, I can see them. So we've got hemoptysis, we've got unintentional weight loss, chronic cough. Yeah, brilliant. So you've basically said them all. So hemoptysis, weight loss, your supraclavicular lymphadenopathy, your finger clubbing, and then this superior vena cava obstruction. So what would you do if you had someone presenting with these? There's the 2-week wait chest x-ray referral, so 40, and you've got any of these kind of red flags or thrombocytosis, persistent chest infections, you would get a chest x-ray. Or there's the chest x-ray pathway for unexplained symptoms, so you're over 40 and never smoked, and you need 2 more features. Or if you're over 40, a smoker, or asbestos exposure, you just need 1 other feature. And they can be quite vague. So loss of appetite, for example. So what's important here is it's quite a low threshold to send someone for a chest x-ray if you're worried about lung cancer. Okay, so superior vena cava obstruction. This is an oncological emergency. So it's one of the things you really do need to, be aware of and know how to recognize it. So you get this shortness of breath, you get kind of upper limb and facial swelling, headache, visual disturbance, and pulseless JVP distension. So what's happening is the cancer is pressing on the superior vena cava, so the venous drainage of the upper limbs and the face and the head, isn't happening. So you're just getting this kind of almost line of where your superior vena cava is and the obstruction happening on it, and everything's just swelling up above it. And so obviously that can be quite serious. You get this thing called Pemberton sign. So raising your hands over your head can cause facial congestion and cyanosis, because if you think about it, if when you raise your arms, the venous drainage increases, but there's nowhere for that to go. So how you manage this is there's endovascular stenting and then radical chemo or chemoradiotherapy. And sometimes you can give glucocorticoids, but there's not that great evidence supporting that. So causes of this, you've got lung cancer, small cell or lymphoma, you've got aortic aneurysm, mediastinal fibrosis, a goiter, and an SVC thrombosis. So they're all quite significant things, and it's important to recognize as it is quite close to your airway. So, you don't want any airway compromise. Okay, so where do lung cancers usually metastasize to? I think there's another poll. Hopefully you can also select more than one option, but if you can't, just pick one. So there's multiple answers to this one, but I think the polls only let you click one answer, unfortunately. Okay, so we've had about the same amount of people respond. So most of you got pretty much all of them. So there's 4 main sites. It's the brain, the bones, the liver, and adrenal glands. And then there's some other sites as well that are less common. So the stomach, intestines, pancreas, eyes, skin, kidney, and breast. But I would remember the first 4. They're the more common ones. Okay, so when you have someone presenting with suspected lung cancer, there's some investigations that you should probably do. I always like to split mine into bedside, bloods, and imaging. So you've got bedside, you do your baseline OBS, examination of your breast, lymph nodes, blood tests. You'd want to do FBC, you can get raised platelets, UNEs, LFTs, bone profile, tumour markers, that sort of thing. And this bombacin can be a tumour marker for small cell lung cancer. Then imaging, your chest x-ray is first line. Often people have chest x-ray first before, all the bloods and everything will come back if it's on a 2-week wait. And then you'd also want to then do a CT to just confirm what you're seeing. So on your chest x-ray, you might see the hilar enlargement, as discussed before, peripheral opacity, pleural effusion, and this would be unilateral. And then maybe a lung collapse as well. So some further investigations, kind of specialist. If you've had your chest x-ray, you'd do a staging CT. So you'd want to look chest, abdo, pelvis, your lymph nodes, look for metastases. And then sometimes you can do a PET CT. So this is when you give a radioactive tracer, so glucose, and it highlights metabolically active tissue. And that can be useful for detecting METs as well. Then you'd want to get a biopsy, as that's the gold kind of standard for diagnosing any cancer, really. And you can do this through bronchoscopy or endobronchial ultrasound. And then you would diagnose it based on the histology. So you can do a percutaneous biopsy as well. And just to note about the mesothelioma, so you have to be really careful when you biopsy a mesothelioma, because the kind of tract you make, the needle tract, when you take the biopsy, the cells can sometimes spread through that needle tract. So you're actually giving them iatrogenic metastases to the skin. So it's just something to be aware of. You have to be really careful. Okay, so management of lung cancer, it's always an MDT. It often presents quite late. There's a lot of things to consider. There's surgery, radiotherapy, chemotherapy, and endobronchial treatment. So there's a lot of options. For non-small cell lung cancer, some of them are suitable for surgery. you can either have curative or palliative radiotherapy. So if you have a palliative treatment, it means you're not going to cure the cancer, but you give the chemo or radiotherapy for symptom relief, and not necessarily to prolong someone's life, but to improve the quality of the life they have left to live. And unfortunately, non-small cell lung cancer doesn't have a great response to chemotherapy. Small cell lung cancer, it's not really operable unless it's in that really, really early stage. For limited disease, you can give chemo and radiotherapy, and for extensive, it's usually palliative chemotherapy, as it's also usually metastatic diagnosis. Okay, so lung cancer surgery. So you can do a segmentectomy or a wedge resection. You can do a lobectomy, you can do a pneumonectomy. And you can do this via a thoracotomy or a VATS or robotic procedure. But there are several contraindications to this. So if you're not well enough to undergo surgery under general anaesthetic, if you're quite advanced, so stage 3, 4, the MET's present, if you haven't got good lung function, if there's pleural effusions, if it's near the hilum, you've got vocal cord paralysis, SVC obstruction. These are all quite significant contraindications to lung cancer surgery. So with a segmentectomy or a wedge resection, this is where your anatomical relevance is really important. As we said before, it's anatomically discrete, so you can take segments and not affect the rest of the lung function, but you need to be sure which segments you're taking out. A lobectomy is you take out the entire lobe containing the tumour, and a pneumonectomy is where you take out the entire lung containing the tumour. So it's a big undertaking. Okay, so just going into the surgical options. So you've got the video-assisted thoracoscopic surgery, or the VATS procedure. So you put the thoracoscope and the surgical instruments through the chest wall, and this is where your anatomy with the intercostal space and the neurovascular bundles is important, as you don't want to damage these when you're going through. So you can do this to diagnose and treat thoracic disease. You can remove tissue as a biopsy, you can remove segments, you can remove fluid, you can do a thymectomy. There's lots of different things you can do, not just for lung cancer. And then you've got a few risks associated, so pneumonia, bleeding, short-term or permanent nerve damage, and the anaesthetic side effects. So this is kind of what it would look like. You've got the patient on their side, and you put different ports in between the ribs, and then you'll do it all via the screen at the patient bedside. And then this is what kind of a wedge resection looks like. So you've got your 2 ports, and then you put in your different instruments to remove the wedge. And this is kind of some pros and cons of a VATS versus open surgery. So with a VATS, there's less post-operative pain. You know, you haven't opened the entire chest, you've just gone through the ribs. But there is the same overall year survival. So, you know, you can always weigh that up. But there is faster recovery, short hospital stays. So if you are only, if you're doing it just to improve quality of life for symptoms, this might be a better option, as there's less pain for the patient. They don't have to stay in hospital as long, and they can get home quicker. Whereas with open surgery, there's a bit of a higher risk of pneumonia post-operatively, as you can imagine. So just to kind of finish off, I've got a video of VATS procedure, because I mean, I've never seen one. So I thought it might be quite interesting to look at. I'm not sure the sound works, so I'm going to put the captions on. So just follow along as best you can. It's just more for interest rather than like kind of you need to know this for your exams. Oh dear, why has that gone up the side? There we go. Okay, so this is where they're doing the VATS procedure now. So they're making the incisions. And now you can see the lungs. So they're doing a wedge resection in this video. Okay, so that was a wedge procedure for removal of a lung cancer. And now this is a upper lobe lobectomy. So they have to divide all the major vessels before they can dissect and remove the rest of the lung. Okay, so you kind of get an idea about, what advanced procedure is, and you can do pretty major surgeries through this really small incision. So you can see how it's desirable for people to have this versus open surgery. Can you see my slides again? Okay, no, that's just better today. All right. So just to finish off, I just thought I'd run through a couple of common OSCE scenarios that I don't want you to throw you off or anything if you were to see this in your OSCE. So you often, when you get to finals, you do have patients with signs. So a thoracotomy scar, they could have had lobectomy, pneumonectomy, lung volume reduction surgery for COPD. So a right-sided mini thoracotomy. Again, this is just a bit of a different incision, but it's for minimally invasive mitral valve surgery. So it's not always thoracic surgery. If you've got absent breath sounds on the entire side of the thorax, think about whether they've had a pneumonectomy. Sometimes, especially in older generations, people had pneumonectomies for TB. So something to be aware of. If there's absent breath sounds, in a lobe, think lobectomy. And again, as I said, this used to be used to treat tuberculosis when the antibiotics and drugs weren't as readily available. So just keep it in mind. And then something else to mention is chest drains. So they're often left in after thoracic surgery, or if you've had a pneumothorax, a hemothorax, anything like that. And as the air and fluid drains, the lung expands, and then the internal end of the drain is placed underwater. So what people often refer to is the chest drain swinging. So this means, is that fluid level kind of swinging back and forth as the patient is breathing? If it's not, it might be blocked, it might not be working, it might have drained everything, but it would need a review to make sure it is working properly. Okay, I know I've covered quite a lot in the session, so please feel free to put any questions in the chat. I'm happy to go back to any slides, and I apologise about the audio. Hopefully it was better once the hotspot went on. I've just put my references at the end, and yeah, thank you for listening. Any questions?
Yeah, so any questions, if you leave them in the chat.
Feel free to just put any questions in the chat, and I'll try and answer them to the best of my ability.
If not, then thank you, Esther, for that. That was very insightful. So the feedback form is now on the chat. So don't forget to fill it out to receive your certificates of attendance and discount codes for Teach Me Surgery and pass the MRCS. And also be sure to complete the Google form for a chance to win free access to the Geeky Medics surgical flashcards and their OSCE stations. And the link for that should also be in the chat. Our next session will cover anatomy of the upper limb on Monday, the 17th of February at 6:30 p.m. And we'd, of course, love for you to join us again. Please make sure to follow us on our social media platforms. And the links for these are, again, available on the chat. And you will be able to receive updates on the upcoming sessions via these platforms. We will also be posting SBAs on our socials for additional practice, so keep an eye out for those. And don't forget to visit our website, where you'll find a resource bank with materials, not just for this session, but for all other sessions in this teaching series. And these resources include summaries and a question bank featuring extra questions that aren't available on our social media. To access them, all you need to do is create a free account on our learning portal. So we hope you found today's session valuable and engaging. Thank you once again for joining us, and we look forward to seeing you at the next session. Seeing if there's any questions that I've missed. Esther, the references, yeah. All right, thank you, guys.
Okay, I think my network's struggling, so I'll probably just head off if that's okay, Luke. I don't think there's any other questions. The feedback form link should be in the chat.
Yeah, I don't think there are any. Right. Can you hear me?
Yeah.
Okay.
Yeah, I can hear you back. I think my Wi-Fi just dropped out, so I'm not sure what happened.
That's okay.
Yeah.